We talk about workouts, hormones, and self-care, but there's one part of women's health that almost never gets talked about: our pelvic health. So many women live with things like leaking, pain, discomfort, or just changes in perimenopause and assume it's the price of getting older. But what if it isn't? Today, I'm joined by Dr. Kim Dixon, a pelvic health expert who works with women at every stage of life. And we're going to talk about what pelvic health is, why so many of us were never taught about it, and how understanding your body can completely change your experience in this season of your life. Kim, it's always a fun conversation because I think a lot of people, this is sort of a closeted conversation, right? People are not sure who to ask or who to turn to, or is this normal? What's probably the number one thing you're seeing in your practice right now?
Women who have a little bit of urine leakage when they work out. That's
Oh,
probably, there's probably that and painful intimacy are the two leading ones that I see.
is this somebody coming to you after they talk to their PCP, or is this something that someone can come to you directly and sort of ask or work with you?
Since I am a physical therapist, we follow the Board of Physical Therapy rules and regulations for each state. And in the state of Virginia, we have direct access. So people can come directly to us. They don't need a prescription from their doctor. I would say most of my clients are word of mouth, that they just come because their friend came to me and I was able to help them. And now they're at burn boot camp or wherever, jumping and doing jumping jacks without leaking. And they're like, oh, you need to go see Kim. I do get referrals from doctors as well, but
Mhm.
interestingly enough, sometimes doctors don't even know exactly what we do as pelvic floor physical therapists.
Yeah. Yeah. The perpetual "is this normal" conversation that we have between women. And I think that's really huge that you are such a great resource. Kim, how did you get started in this field? I know you're a DPTs, you've got a physical therapy background, but what really drew you to pelvic health?
Yeah, that's a great question. And honestly, if you would have asked me like 20 years ago, would I be doing this all day? I would have been like, absolutely not. So I've been a PT 28 years. I started out mostly orthopedics, sports medicine, worked with professional athletes, and it was amazing. And then I became a mom and had my son 18 years ago. And during labor, I actually tore my labrum in my hip. And I
Mm.
didn't know it at the time, but I went home, had a newborn, and I just had this chronic ache in my left hip, and it hurt to lay on it and sleep. Went in, saw the ortho, got diagnosed with a labral tear, and I went and did my own PT and got better for the most part. But there was this little missing piece to
Uh-huh.
the hip pain that I was having. And then fast forward, I had my daughter at 40. I had the amazing opportunity of going through perimenopause and postpartum together. And so then really all my research was me search, trying to figure things out for me. And then as I was able to figure out more things for me, I thought, I can't just keep this information to myself. I have to share this. Like, women are so thirsty for information, and especially at this phase in our life of just trying to understand our bodies.
There's a reason that you have a wait list, basically, right? That folks are coming. It's because they're seeing success with you. But one of the things that you're probably seeing and I'm hearing a lot about is now medications involved in some of the pelvic health. I know we just took the black box off of HRTs, right? And I was just talking to a chiropractor friend who is talking about peptides and all these GLP-1s. But now that we have the black box off of the HRT, and for anybody who's not familiar, because it's been all over the news, it's hormone replacement therapy. So, can you tell us what that looks like involved in your practice or involved in your clients, right? Because I know you're not prescribing. This is coming from their physician.
Yeah. So it really hits on both topics that I brought up. The most common clients I see are leakage and pain with intimacy. And so specifically, I want to talk about vaginal estradiol. And so that usually is a cream, and you can put it inside the vagina, and then you can put it on outside, which is actually called the vulva. I think I'm always really want to make sure us moms and we talk and use the
There's a
right
distinction.
anatomy
Yes.
for kids. And so we can put that on the tissue, and it can just really help the muscles. It makes the muscles improve in suppleness
Mhm.
and it also improves moisture. So the black box warning on vaginal estradiol, like you said, has been removed, which is amazing because I can't tell you how many clients were just terrified to use it and take it. And basically, that misinformation for 2 decades, a lot of women suffered in silence.
And I appreciate you actually talking about the application because I think the other thing is we hear these medications available and we don't actually know the application and what the transdermal essentially, right, or across the skin barrier does. So when we're using these creams, right, they are transdermally being taken in by the body. And like you said, it's direct to the muscle, it's direct to the organ, it's direct to the area it needs to go to, which is really impressive. I just got closed a client session, and this is a client I love and I've known for a very long time. And she, when I brought up this episode and the HRT, she was like, "This is such a important step in women's health, just like breast pumps and things like that." That allows us the freedom or the ability to manipulate how our body ages, in a way that was not possible. She used a couple choice words because she was really upset about the fact that this was not available to her as she was going through menopause. And it's true. This is, what do you think it is making this more available? Is it that the research is better? So now the black box is off? Or is it that maybe the prescriptions are better?
I think what I can tell, and this is based on like some of the Urogyn's, OBGYNs that I follow, they are doing more research. One thing, like to back up, is women were not included or didn't have to be included in studies until 1993. So we really didn't study the
Well,
female body very much. And I think there was just misinformation put out there. And we have some amazing advocates in women's health. Like locally, we're in the DC area. Rachel Rubin, a urologist, is amazing. She was at the FDA. And I had the chance to meet her a few years and I've shadowed in her office. So she's incredible. So there's a lot of really pioneers out there that are really just putting this information out there and letting women know that you don't have to suffer in silence. And the research was really just misrepresented. And so the way that vaginal estradiol helps a client of mine, like I said, in the case of urinary leakage, it can help because it makes the muscle more supple. The muscles will work better. So I can train them on breathing properly and when to engage the muscles and when to
yeah.
relax their muscles. But if the muscles themselves are kind of a little bit more frail and they're not working as well, then it doesn't help as much. So I find for clients, it's a combination, or we've done everything we can as a PT.
Yeah.
And then it's, that last little piece is a little bit of vaginal estradiol. And then they're like, oh, now I don't get up at night to pee anymore. I can sleep through the night.
Yes. Yeah.
And
I don't have to live with these symptoms. This is not, yeah, a sentence.
yeah. And then the other piece, like we talked about, is with painful intimacy. It's because if we use things like lubricant, lube is very short acting
Mhm.
versus the vaginal estradiol is a moisturizer. So that's very long acting. And so, like, we
Yeah.
moisturize our face so
Yep.
that we don't get wrinkles for long term. And so, if lube isn't enough and you're still having pain, then you might want to look at something like vaginal estradiol.
Nice.
Yeah.
Is it specific to menopause or perimenopause, or is it something that's being used in other populations?
There's what's called the genital urinary syndrome of menopause, GSM, but then there's also the genital urinary syndrome of lactation. And what that is when we're breastfeeding, our estrogen levels will go down. And so it's really the lack of estrogen that causes the tissue to be more frail and to have more discomfort and less moisture. And
Mhm.
so it can happen in postpartum and then definitely perimenopause and menopause is where we see it used most often. But it used to be thought of like, oh, I don't get these hormones until I'm in menopause. And now we're seeing many providers saying you don't have to wait that long. If you are symptomatic, they will prescribe them sooner.
It is evolving research. Like you said, it's something that has really only in the last 2 decades had any real grip or real movements as far as medications go. HRTs are awesome. I think we're gonna learn more and more as time goes on, and Wow. The other choice thing my client had to talk about was DEXA scans and bone density, and how if we had had this information 20 years ago, that there'd be far less osteopath and osteopenia issues, right? Let's talk about the therapy, because I think for some people, the biggest hurdle for acknowledging that pelvic health is not or needs to be addressed for them, like you said, is urinary leakage, pain. But I think it even goes further in that case, where a lot of times there's this, you've heard of the frozen pelvis, right? When we get into menopause, a lot of people get frozen shoulders in my line of work. All of a sudden, someone comes in and they're like, I'm having shoulder pain and I can't move my shoulder. But you're seeing frozen pelvis. Can you talk about that and maybe about the modalities of some of the things that you do to work with?
Yeah. So the frozen pelvis, I mean, as we get older, our collagen, our tissues, our connective tissues change. So sometimes that can impact things. Like you mentioned, frozen shoulder. I often see like frozen hip, if you will, like where you're sitting crisscross applesauce and you used to be able to like you notice one knee is not dropping down as far as it used to. And so we see that in the hip joint. We can see it in the pelvis. And I've even see with clients who their bladder can get frozen even after delivery sometimes.
Wow.
And they've
Yeah.
had a catheter potentially. And sometimes then that bladder just isn't working the same. So I think it's just being aware that these things can happen, but more importantly, don't just suffer in silence. If you know you're not, urinating the same, having bowel movements the same, or intimacy is different, to definitely just press on and get that information. And if you're with a provider and they just say, "Oh, that's just normal," like don't accept that. There's no more gaslighting in women's health. And unfortunately, I've seen female doctors do it to females themselves. So if you're going and you're not getting to the bottom of it, just keep asking questions. And there's just such an online movement of women talking about this and being more comfortable. One of my favorite things is when a client comes back and she's like, guess what we were talking about Friday night with my girlfriends at our neighborhood wine party? I'm
Yeah.
like, she's like, oh, we were talking about pelvic physical therapy. And one of my favorite little tips I give people along the lines of pelvic health is
Yeah.
when you're urinating, you want to count the stream of your urine. And if you don't go for 8 seconds, then your bladder wasn't full. So sometimes we will undertrain our bladder, just like any other muscle in the body.
Mhm. Yeah.
And so that's the common one. People come back and like, I told all my girlfriends the 8-second rule. So I have a lot of clients that, they will do the just in case, and so then this can cause some urinary urgency and frequency where I'm going to the bus stop. So let me go to the bathroom just in case.
Tactical wheeze. Yes, of course.
Yeah.
Yeah. Wow. I guess the bigger question is, right, like you said, there's this purity culture where we don't talk about our lady bits, right? Or there was one nurse online that I just made me laugh. She called it a fajuzzel biscuit, and I loved it and I couldn't stop using it thereafter. But it is, we do that with humor, and we basically, in this purity culture, any sort of penetration, any sort of action that's going on there that's not specific to reproduction, or the process of reproduction, it's like we don't talk about it. It's not right. It's embarrassing. It's inappropriate, or somehow it's a morality issue. Would you mind helping me take some of the stigma out of this today? I know you've got the magic model behind you.
Yeah.
So I was like, I love the magic model. I do that too sometimes with clients where I'm like, let me just show you what this ligament actually looks like so we can take the fear out of it. So Kim has a magic model, as I like to call it. And I think when we talk about what a therapy visit may look like, can you help us with that?
Yeah,
Okay.
absolutely. So
Let's take the mystery out of it.
So I actually have a client now. She's had tailbone pain for 10 years. So coccyx pain. I mean, for 10 years, this woman has not been able to sit comfortably. That's a long time. And, we're both from the PT world, and she was going to PT for her back, and no one ever mentioned pelvic PT to her. She didn't even know it was a thing.
Mm-hmm.
So she came in to see me, and first I'll set the room, like how my room is set up. When you come to see me, it's a private room. I have a table, and I always put a warmer on the table, especially this time of year. It feels so good. And then I have music playing, usually just spa music that's very relaxing because, as we know, nervous system is boss. So as soon as someone comes in, I need them to feel calm because it's probably not the most exciting thing they've ever done in their life. And, when we have that annual OBGYN visit, a lot of us are like, oh, let me just get this over with. So, yeah, you come in and what we'll do is I'll do a full history. We'll talk about things. We'll look at your movements. And then with your consent, we can do an internal exam. And what an internal exam is I use gloves and then lots of lubricant. And usually we just insert one finger. And so I often tell clients, this is way less than a speculum. Usually when you go to
Amen.
OBGYN,
Amen. Yeah. Or if you've
they're
had
going
a
to be
child
using,
recently.
yeah, that cold speculum.
God. Oh, God.
So, yeah, so it's just one finger that's inserted. And actually with the pelvic floor, there's 3 layers to it. So it's a slow process, but we'll check each layer of the pelvic floor. I check all 3 layers of the pelvic floor. Here's my little pelvic model. This one is magnetic, but unfortunately the magnets don't work as well. So this is the first layer right here. And so right here, I place my finger at the opening. That's called the introitus. And usually I will just after I've assessed externally, just looking at the tissues, and I'll have you contract your pelvic floor and relax and
Mhm.
just look at it externally. So there's a lot we can tell externally too. So if a client's not quite ready for an internal assessment, we can teach them a lot just from an external assessment. Then, with your permission, I will gently insert my finger just a little bit to check out that first layer of pelvic floor muscles. And I'll have you squeeze and then relax. And then I'll, with your permission, check the next layer. This will come off. And then we check theirs is
It
first
doesn't
layer.
actually fall off during the exam,
No,
but
it does. And my first and second layer are combined here. So here's our third layer, which I find absolutely fascinating because this
yeah.
is look at this. This is our levator ani. These are the muscles that
Yeah.
hold everything up and in. And so our bladder, our uterus, it's kind of a huge job. We have bones right here, but ultimately muscles are what really hold everything up and inside of us. So what's really neat too about the pelvic floor, a lot of people will say it's just like doing orthopedics, but in a cave because
Okay.
you're in a small place,
It's
right?
true. It's true, right? Yeah.
Um, is just like the rest of the body, we have fast twitch muscles and we have slow twitch muscles. And so they're type 1 muscle fibers and type 2. So if a client has issues like with urinary urge incontinence, like you pull in the driveway, you're getting to your front door. We used to call it the key in the door, but people
Yeah.
don't have keys
Like
anymore.
that's
They
like
have
the yep.
codes.
Yep.
So, and they get a little bit of leakage. So that's urge incontinence. And when we
Okay.
have that, that's more the type 1 muscle fibers, which are the muscle fibers for like cross country running, like more the endurance muscle fibers. The second type is the type 2 fibers, which are the fast twitch muscle fibers. So think more like a sprinter. And so if you're having leakage with things like running, jumping, coughing, laughing, sneezing, those are more the type 2 muscle fibers.
Hmm.
So
Okay.
it's really important because there are some products out there like biofeedback units. Even some insurance companies will say, oh, you're having pelvic floor symptoms. We're just going to send you this in the mail.
Okay.
And unfortunately, there's not often a lot of instruction. But if a client has one, I'll say, bring it in. I'll show you how to use it.
So it's a device, right? It's the
Yeah.
device that you
It's a,
squeeze into. It gives the feedback.
yes,
Okay.
biofeedback. And then you
Biofeedback.
can even, some of them they connect to your phone. And it's like you play a little game on your
I have
phone.
seen this. I think that's actually it's so funny how we want to add shame and morality to things, or if we just don't talk about it, it'll go away. If we talk about it, it'll go away. But I mean, how many people do you know of a generation beyond us who just live with these symptoms because this is how it's always been? Whew, we're going to save a whole generation of women plus today. All
Yeah.
right. So the device itself is something that can be obtained through your insurance, right? And do you have one with you?
I have my lipstick.
Perfect. Okay. This is
So
perfect. This is what I
actually,
do.
it's probably one of the ones. It's called Pelvic. It's about this height, and then it's just instead of rectangular, it's more rounded.
Mhm.
So it probably is about this height and this height and maybe a little bit wider, but not much. But you would insert it. It's more bulb shaped, so it's more comfortable. So
Yeah.
that is kind of like what
Think
one of
think
them is.
tampon, like sort of tampon
Yeah,
entry point. Yes. Okay. So if you've
yeah.
inserted a tampon before, my friends,
Mhm.
this is something you can do. In all these years of PT and working with people, it's funny how little exposure I had to understanding fast twitch and slow twitch muscles in that pelvic area. I love that. Now, it also affects the hips, right? We also have that psoas coming in here. We also have some muscles adjacent to that. And that may or may not be pelvic floor specific, but it can be a part of the health complex. Is that right?
Yeah, absolutely. So once again, like I said, my tore my left hip labrum, and so the missing part for my rehab was the pelvic floor, and then there's another muscle in the pelvis called the obturator internus, and this muscle is really it's fascinating to me because it comes out of what's called the obturator membrane, which is right here on the pelvis. And it comes out of here. It comes from here. It goes around. I don't have a femur attaching here, but it attaches to the femur.
Leg
So it
bone. Yes.
makes the thigh bone, the hip bone, and it makes a 120-degree turn. I'm like, that design is incredible. So
Yeah.
what's really neat about that muscle is it does the same actions as our glutes. And so it's a hip extensor, it's a
Yeah.
hip abductor, hip external rotator. And so sometimes what we'll see is if that muscle is tight when I assess that during assessment, if I notice it's tight, it could be because it's trying to act like a glute, but it wasn't designed to be a glute. It's a smaller muscle. So and when we have muscles that act like that, then there creates dysfunction and balance, which can cause sometimes pain and definitely weakness.
Yeah.
So we like to assess that muscle in particular that really directly affects the hip. But in general, if you think of the pelvis and like that bowl, kind of almost like a hammock between your hips,
Hmm.
any part of it, if one part is tighter, you can see how it would definitely like throw things off. Or especially new mamas like yourself and many mamas that are probably listening to this, we often hold a baby on one hip. How often do we do
Worse.
that?
Yes. Yeah. We got a
And so
favorite
then like,
side. Yeah.
yeah. And so then we can create some asymmetry in there.
Well,
Um,
you are doing the Lord's work. That's all I'm saying. But I think the other thing is, sometimes in my world, we instantly go to the major muscle groups, right? We instantly go to those glutes. We instantly go to those quads when we see back and hip and lower body pain. So I love that you're giving this additional information that there are these funky muscles, these muscles that maybe haven't thought about where they could be tight, right? Is that you were saying tight?
and that along those lines, tight muscles, we think, oh, it's tight, it's strong. No, tight muscles are weak. We need
Mm.
length for
Hmm.
strength. So, just this is kind of my public service announcement. Kegels don't fix everything, and sometimes it can make it worse. So, if your pelvic floor is too tight and you think, oh, I need to do 1,000 Kegels a day, you may actually be making things worse. So,
Thank you for saying
um,
that. I think
yeah,
sometimes we think more is more when it comes to something wrong with our body or something that's not functioning properly. I always hate to say that there's something wrong with our body. If something's not functioning optimally, we right away go into the category of we're not doing enough or we push harder, right? And I think this is a great example in you saying this is something that needs to be relaxed. This is not something that needs to be addressed. This is something that needs to be realigned as opposed to go harder, do more exercise, do more Kegels. Kim, if somebody is not aware that they're getting into menopausal symptoms, what are some of the first things, perimenopause, what are some symptoms out of the gate that may not be typical or internet worthy or we're not having hot flashes? What are some things you're seeing that might give people some insight into, oh, this is a shift I should pay attention to?
yeah, I would definitely say the mood changes. I see a lot of mood changes. And like for myself being postpartum, it was really hard to discern what was postpartum hormonal shifts and perimenopause. So
Mhm.
sometimes it's not clean. We're going through other things in life, or sometimes we're stressed and we think it's just stress because of something happening with our kiddos or our parents or something. So the mood changes. I think one of the biggest things is like women just say, I just don't feel like myself anymore.
Mhm.
And listening to that. And I can't tell you how many clients I would say, and this has gotten better in the last 5 years. So I'm so excited about this. They would come in, they would see me, and they would say, I went to my OBGYN, they did my blood work, and they said, oh, nope, you're good. You still got lots of eggs. You're not in perimenopause. And then it's like gaslighting them because then you're like, but what's going on with
What's
me?
wrong?
And
I know something's not right. Yeah.
so I would have to gently approach it and say, when we get that blood work, once again, in the last 5 years, it's been a lot better. That's just a snapshot in time, that moment, that second of the day where your hormones are. So it doesn't mean you're not in perimenopause. And I think as daunting as it may be, like it might make you feel like, oh, I'm in perimenopause. It means I'm getting older. I find it extremely empowering because then you understand what is going on with your body. And I want to be the first to say, if you haven't heard this, it gets better. This isn't like this downhill
Yep.
slope
Yep.
decline. Is perimenopause is a little bit of a roller coaster, but then on the other side of menopause, things even out a bit.
Yeah.
And it's like even brain fog gets better. They have like neuroscientists, Lisa Mosconi does like great research in this area. And they look at the prefrontal cortex and they look at the brain and they look at it in puberty, before having kids, postpartum, and then perimenopause and menopause. And it actually does improve. So there's a lot of things that improve. I don't want it to always be doom and gloom because it's really not. So
It's just a chapter. And in some ways, it's no different than your childbearing years, right? Your actual years is your body is in a certain chapter, whether you're actually pregnant or lactating. It's just a chapter. Perimenopause is just a chapter. Menopause is just a chapter. So I think that's one of the things when you said it's sort of like a death sentence. This is the end. Blah blah. You're not in menopause forever. I think maybe too many TV shows have taught us that like any woman over the age of 45, well, that's it. It's too much, it's that's the end for you. And it's
yeah,
quite the opposite on the other end. I don't
yeah,
think we get enough publicity on that end. It's quite a different and easier life in a lot of
yeah,
ways. I think we discount some of our puberty years or our years menstruating, right?
yeah,
Because we're like, oh, this is where our value comes from. This is our purpose. And not to go too deep into this, but like when that sense of purpose is ending, if I'm no longer reproducing, who am I and what do I do? That's a step deeper. And as you illustrated, as you pointed out, it's an even better chapter in a lot of ways. Like there's just you have so much wisdom and you have so much confidence on that other side. And I just love that you have dedicated yourself to getting people across that bridge in so many ways because we do deserve any sort of therapy that is going to get us there. And we should never feel bad about asking the questions or being curious about what's going on in our own body.
yeah, absolutely. And the highest rate of suicide for women is during menopause. And I think we shouldn't like ignore that. I think it's like 45 to 55, something like that. I'll have to look it up exactly. But it's all these changes and we don't understand our body. And I
It's
talked
a
about
lack
the
of support. Yeah.
yeah, mood changes. But also we'll see fluctuations in our period where you see your period's heavier, it's lighter, or it's like last month it was 40 days and now it's 18 days.
Hmm.
Those are some of the other fluctuations we see. I think just talking about the symptoms you're having, and a lot of times you talk with your friends and they're like, oh, yeah, me too. I think for me, I went through it early. So I felt very alone. And I think that's my other mission is I don't want anyone else to feel alone going through it so early. And, just to clarify some of our terminology we're using, perimenopause can last up to 10 years. Menopause is the day you have your last menstrual cycle, like
Hmm.
menstruate, pause, like that's it. Some people will use the term postmenopausal, like after that day. Some people continue to say menopause the rest of your life. So just to go over some of the terminology. So if menopause typically happens between 45 and 55, you could potentially be experiencing perimenopausal symptoms in your mid to late 30s. I think just being aware of that and recognizing it, and once again, knowledge is power.
Yeah.
Once we understand it, then we can do something different. And it might mean that we need to change up our workouts. We need to do more strength training.
Indeed.
We need to have more protein. We need to change it up because there is some weight gain sometimes that happens during this time. And, you can feel like your body's been hijacked. So
Yeah.
taking back your power and recognizing, okay, this has changed. This is different. Now I need to eat a little bit more protein or I'm gonna start lifting heavier. And even for me at
You
like
can.
50, I got my doctorate. When you talk about like this like phase of life, I was like, that's it. I'm getting my doctorate at 50 years old. I ran my first Spartan race. I have my own business. So for a lot of women, like this can be a very exciting time
Transformational
where,
time. Yeah.
yeah,
Kim, thanks for doing this. Thanks for having this conversation. I always love talking to you because it's just the honest truth. It is what it is. There's no shame. There's no judgment. Kim, how can people get more of this conversation or what you're doing?
yeah. So I'm on Instagram a bit at PT Kim Dixon. So P is in physical, T is in therapy, and then Kim, Kim, Dixon, Dixon. So on Instagram, I try to put some information out there, educational things out there. I have a website, Pearl, like the jewel, the pearl, hyphen physical therapy, all one word, physicaltherapy.com. That's my website. Got some free downloads there. I've created a postpartum guide. So even if you can't come see me in person in Northern Virginia, you can get my postpartum guide and just know that you're doing exercises that have been created by a pelvic floor specialist, certified specialist. The weight loss company Noom, you may have heard of Noom. They have
Yeah.
an app called Noom Vibe, and that app is a free app. The second Friday of every month, I'm on there doing Friday fitness fundamentals as a guest.
Wow. Yeah. Kim, thank you so much for being here today. If you know somebody who could really benefit from this information, aside from yourself, ladies, let's be honest, there's things that we just don't know and we shouldn't be afraid to ask, but share this with your friend. And maybe this is how you start that conversation with those you love around you about it's okay to ask for help. It's okay to not know. Kim, thanks for being with us today.
Yeah. Thanks for having me.